Hey everyone, it's Friday. That means it's a compilation video time for what we've been talking about this week on Instagram and Facebook with the stories there. So this week's theme basically was menstrual or related disorders. So, and we touched kind of on three main topics over the week. We talked about menstrual-related migraines. We talked about catamenial epilepsy or menstrual-related seizures. And we talked about the perimenstrual mood disorders like PMS and PMDD. I really tried to throw out with these that these conditions are very closely related to changes in hormones. And that's really the big thing with all of this. You know, if you look at the menstrual cycle, and there's a video I put on YouTube about the menstrual cycle in detail. As the luteal phase ends, that's the phase of the menstrual cycle that occurs after ovulation, you have a drop in estradiol and progesterone if a person does not get pregnant. And it's that drop that really starts this cascade a lot of times of these menstrual-related changes. And really this is due to an efflux of hormones from a lot of the very important estrogen receptors within the brain. And obviously when hormone receptors are not filled, there are issues that occur after that. So anyway, let's talk on each of these things kind of individually, and we'll go from there. So to start off, menstrual-related migraines, once again, that drop in estradiol starts to precipitate a kind of vascular change within the brain itself, and you can have vasospasms that occur that lead to migraines. Now, by themselves, a hallmark of menstrual-related migraines are that they occur without aura. Now, really, this is something, that occurs in patients that don't have migraines outside of that, because you can definitely have migraines that are hormonally mediated that do occur with aura. But for women that have, individuals that have menstrual-related migraines, just that's the only time they get the migraines. Typically, they are going to occur without that visual change or sensory change or whatever it may be that the aura decides to be. As a general rule, there's not really a specific place where these migraines occur. You know, they can be kind of more behind the eyes. They can be on the side of the head, like on the temple and the back. But they can be very severe. You have patients that are unable to work or go to school or do things because those migraines, occur. And obviously, if you have a history of migraines, then you are more likely to, kind of have these type of issues. Now, for people with migraines, just in general, if they're taking birth control or any type of hormonal contraception, there's kind of an adage that if you have auras with your migraines, you do not want to be on an estrogen-containing contraceptive. And the rationale behind that is because oral estrogen can slightly increase the likelihood of developing blood clots, like DVTs and pulmonary emboli and things like that. And there's a higher association for individuals who have the migraines with auras if they're taking that, hormonal contraception with that estrogen to have those kind of side effects. So typically for those individuals, if we are going to do contraception that does have hormones, we want to try and stick with progesterone only. Now, that's not a hard and fast rule. Obviously, every person's different, and you have to kind of, tailor medicine to each individual person's, health needs, but that's kind of a generalization. Now, for menstrual-related migraines alone, there's a couple different ways to, go about treating these. And you're really kind of looking at, are we addressing things from the migraine standpoint? Or are we addressing things from the hormone standpoint? From the hormone standpoint, once again, just like everything else, and you're going to see this theme throughout this video, as kind of menses approaches and those estradiol levels start to decline, if you supplement them and kind of keep them from dropping as much, you can get a reduction in these symptoms. And to some patients, they might not have migraines at all if they have a little bit of extra estradiol in the luteal phase. And that can be done either via an oral estradiol supplementation, can be done via combined hormonal contraception. There's a bunch of different ways about doing that. There are some other therapies too, if you really start delving into this, if you have patients that are really recalcitrant to traditional hormonal therapy, you can look at things like gonadotropin, analogs, which are hormones that come out of your brain that tell your ovaries what to do. But really kind of the mainstay is going to be using some sort of hormonal medication that boosts that estrogen level in the end. Now, from the migraine standpoint, you've got the whole list of migraine, medications, everything from triptans to, Max Salt to kind of some of the new injections to Botox. I mean, there's a whole slew of stuff there. I'm not a neurologist. I don't deal with migraine medications much, but I do know that, like I said, those are standards of therapy as well. And obviously the caveat with this is if this is a new onset for you, even if it is just menstrual related, you do want to have that evaluated because there are some things that can happen that can mimic this, that can occur in your brain, brain tumors, obviously, head trauma, things like that. And especially if this is associated with a newer onset of nipple discharge, you really want to get that looked at because that can be a sign of what's called a prolactinoma, which is a tumor that we see fairly commonly in reproductive age individuals. So anyway, menstrual migraines, look at them basically from either migraine therapy or hormone supplementation in the end. Hallmark sign of menstrual only migraines is migraines without aura. So yeah. So moving on to catamenial epilepsy or kind of hormonally related epilepsy. Now, in my story, I may have kind of inadvertently said that this is really only as it approaches menses. And while that's the main kind of subset of this, you can have these epileptic instances occur throughout the entire menstrual cycle too. So forgive me if I kind of just, directed you if you thought that was it. It can be any type of hormonal changes. And, the menstrual cycle has lots of hormonal fluctuations, obviously. But, the true menstrual or menstrual-related epileptic seizures are ones that occur prior to the onset of menstruation. And once again, this is going to be something that you're going to see, like with any other type of epileptic, event that kind of falls into the generalized epileptic subcategory. So you can have loss of consciousness, loss of memory, alterations in taste, smell, incontinence, and can even go into the full-blown kind of tonic-clonic type seizures, like what people kind of generally think about with seizure activity. As always, new onset seizures, you really need to get those evaluated. An EEG or an electroencephalogram is kind of the main way of looking at that, but also doing, once again, brain imaging to make sure there's not a tumor or something like that that's causing this. Now, treatment for these is very individualized. So obviously you have all the anti-epileptic drugs, things that kind of alter the seizure threshold in the brain and kind of the ability for the neurons to kind of have their electrical changes as they kind of fire and everything like that. And once again, not a neurologist, so I'm not going to go delve into a bunch of those anti-epileptic drugs. From a hormone standpoint, it's really interesting though, because estrogen actually has a pro-seizure activity. And this is kind of, we see this sometimes in a condition called eclampsia that can happen in pregnancy. If you have a patient that becomes pre-eclamptic, she has high blood pressure, starts spilling protein in your urine, things like that. If that's not treated, it can progress to eclampsia, which does present with seizures. And the reason is because those high levels of estrogen in pregnancy can decrease that seizure threshold and make it easier for you to have those convulsions. So estrogen alone therapy or estrogen, monotherapy with estrogen is actually not what we would do for these patients. So this is something that progesterone, which is also high in pregnancy, so go figure, would be the kind of hormone of choice for this. And so we would put them on a progesterone-only type of medication, and once again in the luteal phase, kind of after ovulation there, prior to the onset of menses. Now, for catamenial seizures plus, menstrual-related migraines, a potential option is to do something that inhibits ovulation in general. And that can be something related to kind of continuous hormonal medications, whether that's a birth control pill you're taking every day, not having that week off, something like the Nexplanon or, hormonal IUD, or even doing, like I talked about, those gonadotropin analogs. And those basically kind of put patients into almost like a medical menopause. Now, that may be a little bit severe, but that is, an option for people that really have their lives, horribly affected by by this condition. Obviously, once again, like I said, new onset seizures, you need to be, checked out. Progesterone therapy tends to be the mainstay when it comes to hormone therapy itself. Now the other thing with seizure activity is to really make sure that you have a good and varied diet. Magnesium supplementation is really helpful, calcium, vitamin D, staying away from inflammatory foods. And there's actually a whole, diet that you can do for individuals with different types of epilepsy that's been shown to decrease seizure threshold. I can't remember exactly what it's called off the top of my head. But like I said, if you do suffer from catamenial epilepsy, you can Google catamenial epileptic diet. And like I said, it's going to be an anti-inflammatory type diet specifically to decrease those kind of side effects. So finally, kind of talking about the perimenstrual mood disorders, you have PMS or premenstrual syndrome, and then PMDD, which is premenstrual dysphoric disorder. Now, PMS in its variety, in its spectrum is incredibly common. Almost all individuals that are menstruating will have kind of a change in mood prior to the onset of menses. They can become more irritable. They can become, kind of more aggressive. It's very individualized. And we also see this a little bit prior to ovulation too, because you have this kind of fall of estradiol. Once again, it's not as severe, but around ovulation or right after the egg is released. So, when you're looking at PMS or any of the perimenstrual mood disorders, you want to kind of take that into account as well. Is this something that a patient has mid-cycle mood changes too? And if so, doing something more continuously would probably be a good treatment option for them. Typically for PMS that's severe, or even PMDD, like I said, we have kind of two schools of thought. Once again, we have the hormone side of things, and then we have the, in this case, antidepressant side of things. From the antidepressant stuff, you've got a wide variety of antidepressants to choose from. They all have their own kind of little nuances there. Prozac is probably the most well-studied in this instance, just because it's been around for the longest. But, patients, if they have really high anxiety, may do well on a medication like sertraline or Zoloft. Or if it's just pure anxiety, maybe an anti-anxiety medication like Buspar would be a good choice for them too. It's very individualized. And one of the nice things about the perimenstrual mood disorders in terms of those type of therapies is that often a patient does not have to be on that therapy continuously unless she or, they have issues with ovulation too. So it may be something, once again, that once ovulation occurs, that's when they start taking that antidepressant medication. The same goes true for hormonal supplementation. Once again, this one is an estrogen related, much like our our migraines. And so doing estrogen supplementation in the luteal phase can be really helpful for these individuals. Now, there is a subset of PMDD that is really more of an anger irritability type subset. And what we'll see in those individuals is a rise in testosterone close to menstruation. And these are typically people that may have, lost their job or had school or relationship issues because they get so angry or mad and they lash out and they hulk out as menstruation approaches. And so for these individuals, actually doing a testosterone blocker can be really helpful. Medication like aldactone or spironolactone is very, very cheap. It's readily available, and it can be a godsend for these patients too. So once again, you're kind of looking at, do we want to try something along the, neurotransmitter affecting medications like an antidepressant? Do we want to do something hormonally speaking? It's kind of an individualized thing. Now, PMDD specifically is going to be symptoms similar to PMS, but ratcheted up to a significant level to where they're affecting overall quality of life. For these individuals, you will have very severe anxiety, severe depression, severe anger. They may not be able to function in a few days prior to the onset of menstruation, or the week, prior to the onset of menstruation. I remember one time I had a patient that basically that week before, she would not leave her house. She could not. She had crippling social anxiety kind of when that happened. She could not be around any other people. And when her period started, boom, symptoms got better. So, and that's the thing that we see. And very rarely with patients with PMDD, hospitalization is required to keep them safe and keep those around them safe too. So, obviously, this has been kind of an overview of a bunch of these things. So if you have specific questions, let me know. Next week is spring break, so I'm not going to be doing any type of social videos or social media videos next week, but I'll see you the week after that, and we'll touch on some other topics. So otherwise, I hope you have a wonderful day and a good weekend, and I'll talk to you later. Take care. Charge of your own health.